Today I will discuss the toxic effects of heavy liquid in the anterior chamber through a case which presented with heavy liquid in the anterior chamber and showed corneal changes. Heavy liquid was presented to ophthalmology during the 1960s. During the 1980s, it was widely used as a tamponade agent and vitreous substitute. Shortly after, everyone realized it's very toxic to the ocular tissues. It mainly initiates cytotoxic effect through initiating inflammatory response, either in the retina, which ends by photoreceptor damage, or in the cornea, limbus, and conjunctiva. 66-year-old male who lost vision in one eye following several retinal detachment surgeries. He had his last retinal detachment surgery on July 2020, after which he accepted having perception of light vision in this eye. His ocular pressure was controlled by topical bimatoprost eye drops at a level of 18 mm mercury today. Examination today revealed heavy liquid bubble in the anterior chamber. During his last surgery, heavy liquid was used to flatten the retina. Then heavy to air exchange was performed, followed by inserting silicone oil. The silicone oil used was 1000 centistock. It wasn't the 1300, wasn't the 5000, was not Densiron or heavy silicone oil. After this last surgery, the retina did not flatten, and a big heavy liquid bubble was detected in the AC since his first post-op visit. I took a photo of the anterior segment, and as you can see here, I was thinking if this is Densiron bubble, heavy silicone oil bubble, or a heavy liquid bubble. So if you look at the contour, it's quite a big bubble, and its contour is not flat. Heavy silicone oil will be flatter in contour. Just think about it, just like the emulsified pseudohypopyon of the normal or the regular silicone oil. So it has a flat edge. Because of viscosity changes between both the heavy silicone oil and the regular silicone oil, the heavy silicone oil will have somehow curved, but the heavy silicone oil will be like a bubble, will be rounded like that. Another thing to differentiate physically between heavy silicone oil and heavy liquid is emulsification. So heavy liquid does not emulsify. Clinical examination revealed corneal endothelial changes as well, in the form of moderate gottata, and this raised concerns about the right eye, which is the only seeing eye at the moment. He has cataract that will need to be done, and I needed to investigate the endothelium, and clinically it was within normal limits. This proved afterwards, as I'm going to the next slide. There was no evident endothelial changes. I performed a SPEC mic. Gottata confirmed. There was low endothelial cell count in the left eye, 1300, and the right eye was normal at a count of 2750. The cornea on the left side was slightly thinner, but there was no corneal scarring no active keratitis, no active limbitis. This is a SPIC-MIC photo, and as you can see here, there are evident gottata in the left eye, and the right eye looks really within normal limits. Heavy liquid in the anterior chamber. First of all, if we have a little discussion on the physical properties of heavy liquid compared to silicone oil, heavy liquid is less viscous than silicone oil. Both the silicone oil, the regular silicone oil, and the heavy silicone oil. So the ones used in ophthalmology are up to 8 centistalk, which is a measure of viscosity, and the regular silicone oil is 1000. Another variety is 1300, and the Densiron is approaching 5000. There are other more viscous heavy liquids, but they are not usually used in vitreoretinal surgery because they are very hard to remove. And it's scientifically proved that viscosity is not directly related to flattening the retina. So the weight of heavy liquid is due to the more fluorinated atoms in its chemical structure, while silicone oil is more viscous because it has longer polymers, and breaking these polymers leads to emulsification. Heavy liquid in the anterior chamber. Contact between heavy liquid and endothelium leads to corneal endothelial toxicity. There are early localized changes at the site of contact, especially if a small amount of heavy liquid travels or migrates to the anterior chamber, which happens usually after 48 hours from the surgery. Heavy liquid starts to break into bubbles, and these bubbles travel through the pupil, especially in aphakic or pseudophakic patients. And at the sites of contact, there are early localized changes with endothelial cell loss. These are usually compensated changes if timely intervention is selected, but prolonged contact leads to irreversible corneal edema. Changes happen in the epithelium as well, so there are corneal epithelial changes leading to persistent corneal epithelial defects, limbitis, and conjunctivitis. All this is secondary to inflammatory response. So even histopathology from keratitis patient with heavy liquid in the anterior chamber showed cellular infiltration of the stroma with inflammatory cells. And this might be the reason for secondary high ocular pressure, secondary ocular hypertension, which happens mainly again due to inflammation, induced uveitis, and inflammatory cellular response. If this left untreated and the heavy liquid is not taken out of the eye, prolonged course leads to deep corneal vascularization and permanent endothelial dysfunction. Deep corneal vascularization is in contrast to superficial corneal vascularization, which is secondary to ocular surface disease and can be managed by few things like oral doxycycline and fine needle diathermy. But deep corneal vascularization cannot be cauterized, they will recur again, and it will make keratoplasty very difficult, penetrating keratoplasty very difficult, with very high chance of rejection. What's the time frame for such changes? Within few days, 2 to 3 days, endothelial toxicity starts, leading to corneal edema and Descemet's fault. So this needs to be differentiated from post-operative corneal edema. If a patient underwent vitreoretinal procedure with heavy liquid involved and he's developing Descemet's faults or corneal edema, we need to look thoroughly into the anterior chamber. Within 1 to 3 weeks, there is inflammatory response, cratic precipitates from the uveitis, aqueous flare from the uveitis, and as we mentioned, histopathologically there will be stromal infiltrates and endothelial degeneration. In 4 to 12 weeks, if left untreated, here starts the irreversible changes phase. There is foreign body inflammatory reaction, as seen in histopathology, and deep stromal vascularization, making penetrating keratoplasty very difficult. More than 3 months, there is permanent corneal decompensation. In the early phase, corneal decompensation takes place in around 10% of patients, and this is usually reversible. And the reason I'm emphasizing that is, for a VR surgeon, you need a good view of the retina and good view to operate. Having corneal decompensation in such an early phase, usually 1 to 3 weeks, makes your surgery really horrible and undoable. This all depends upon the volume of the heavy liquid, the amount of the heavy liquid, the time of contact, how long it has been there, and the prompt management. 75% of patients with long-standing heavy liquid in the AC develop permanent corneal decompensation. Fortunately, our patient did not develop this. Thank you.